Thank you again, Dr. Villarruel. And I'm delighted to introduce our next speaker, our last speaker for the morning. So keep that energy going and hang in there. This is our last treat for the morning, and then we'll be having closing remarks and pulling this all together. So our next speaker is Dr. Marc Nivet, and I introduced Dr. Nivet yesterday, but I didn't have time to read the full intro, and I'm happy being that he has he's given me the wave, don't do that. But I'm going to give him the intro. Here we have Dr. Marc Nivet, and he's the Chief Diversity Officer for the Association of American Medical Colleges, AAMC, where he provides strategic vision and programmatic leadership around diversity and inclusion. Through his advising, lectures, and writing, Dr. Nivet works to reframe the narrative around diversity, positioning it as a driver of excellence and highlighting the link between community engagement and health equity. What I didn't get to share with you yesterday, and this is important, is that Dr. Nivet serves the diversity and academic medicine communities on a variety of boards and commissions. He's a member of the NIH National Advisory General Medical Sciences Council, the Robert Wood Johnson Foundation's New Careers in Nursing Scholarship Advisory Committee, the Arnold P. Gold Foundation Board of Trustees, the American Dental Education Association's Commission on Change and Innovation in Dental Education, the Beyond Flexner Advisory Council, the ETS Policy Evaluation and Research Council, and the Centers for Disease Control Medical College Roundtable. With that, I am delighted and honored to introduce Dr. Marc Nivet.
Thank you, Patrick. Thank you. Thank you. It is wonderful again to be here and to be here on the second day. I'm really glad I sat through the first day. I think listening especially to the two previous speakers, I think my talk now falls into that category of everything has been said, but not by everybody, so now it's my turn. So I'm going to try to truncate some of my presentation. But the other good thing about participating yesterday for me was it reminded me of this video that we created out of my office to really illustrate. It's a 7-minute video, so I'm going to play it for you. But it really illustrates where I have been trying to take the diversity movement, which is really the theme of this conference, which is to say, let's really talk about diversity as a solution to those other two Ds. It's not the same. We've thought about it historically as a problem, something we've struggled with, this idea of diversity. But it's actually a tool that, if we harness it properly, helps us address and think about those social determinants of health and ultimately eradicating those health disparities. So if you bear with me for just a moment, or just 7 minutes, I'm going to play this video. And what surprised me about it when we played it in the academic medical community is how many people came up to me and said, can we use this as a teaching tool? And we said, of course. So this is on our website. It's free. You can download it. We can send it to you if you think it has utility for your students. I think just as the last question was posed, how do we inform our students about the realities of what's going on? So let's play that video. So no verbal narrative needed beyond that, right? Clear. I have to tell you a funny story. So we created this last year in anticipation of delivering it at our AAMC annual meeting, which is about 4,000 individuals attend our annual meeting at the AAMC. Our president gives a big speech. In front of the 4,000 or so folks, and several of us in the leadership team get to give talks at the annual meeting as well. So it's made up of all of the academicians in the nation's academic health centers, 139 or 138 medical schools and over 200 teaching hospitals. And I created that video and I said, well, this is where I get fired. Because they're gonna see this and go, there's nothing we can do about that. That's so outside. Why are you even putting that into our AAMC annual meeting? And I was shocked and surprised, pleasantly surprised, that the community rallied around it. And someone said it earlier, that we really recognize that we understand all of this. Our problem is, what do we do about it? How do we firmly interdigitate all of these concepts into our teaching in all of our academic environments and all of the health professions? So I hope you will, again, find some utility in this video. It is free. We give it away to anyone, so if you want to use it with your students, your faculty, it's just a good talking point. So let me pivot and really get to the point of specifically why I think I was invited here. The diversity component has been talked about a lot, but let me try to sort of shift the paradigm in the way we've talked about diversity. And let me start. I'm going to go through this really quickly because I just used 7 minutes, so I'm going to go through this really quickly. So here's what I think's been happening, and I think it's been said. There's been tons of action. All of you, those poster presentations, a lot of work is happening, right? It's not that people aren't trying. It's not that our institutions don't care. It's not that the faculty don't understand the issues. There's a lot of effort and a lot of energy. But we haven't been able to make these initiatives stick. So there's always funding issues. So we're talking about whether the federal government is going to fund HCOP COE through HRSA. We're talking about philanthropic organizations sort of pulling away from funding these kinds of initiatives in the past. I remember in the early 2000s, many of the philanthropic organizations really said we're not having the kind of traction or success that we're looking for in these initiatives, so we're going to pull that funding and really rethink these issues. So it's not for lack of effort, it's for lack of understanding of the impact of that effort that we've struggled. So we have made some progress, right? It's not all depressing. If you look over the last 50 years, quite frankly, the numbers have crept up. It's the pace to change hasn't been suitable. We have made progress in medicine. You've made progress in nursing. We've made progress in dentistry and many of our allied health professions, but the progress is slower than hoped for. So what we're trying to do, and I think a big part of this conference, and I think what HRSA is really interested in, is how do we accelerate progress? So I want to come back to that a little later in this presentation. Some of the core problems we have is that structural barriers remain. So what do I mean by structural barriers? We talked a little bit about it yesterday when we talked about our K through 12 system. I talked about sort of the under 18-year-old population being at parity in this country in terms of minority majority, but the structural barrier, if you think about where those kids go to school, again, they're in New York City, underperforming, I'm generalizing here, Los Angeles County, Detroit, Atlanta. What do all those school systems have in common? For the most part, they're all failing school systems, right? They're all, if you look at the grades across the country, they're all institutions that fall really, really low in terms of rising to the top as the data has been pulled out. And that's where the vast plurality of our minority students are coming through. So that's a structural barrier that we have to intervene in, we as nursing schools, academic health centers, education, higher education writ large needs to engage in different ways. The other structural barrier is really just a fundamental one. There are many, but just to pick one so that I'm not saying it's all outside of our doors. It's our admissions processes. If you think about what are we looking for when we're looking for students, right? Coming into our door, our applicants, right? So you're looking for some standardized exam, some high score on the standardized exam. You're also looking at GPA, right? So you're looking at those cognitive variables. That's necessary. There's nothing wrong with that. But what do the cognitive variables tell you? They tell you who has the ability to graduate our particular school. It doesn't tell you anything about who has the greatest capacity to serve. All right? So fortunately, in many of the health professions, we do more than look at cognitive variables, right? We do interviews, we bring people in, and we're looking for those other attributes and experiences that individuals have. Well, that's a good thing. But what's the weighting often in our decision-making architecture in terms of who comes into our schools? We default to high cognitive scores. Why? Well, if we're being frank, it tells us as an institution we don't have to work as hard or develop as much structures and systems to ensure that these kids with the lower cognitive scores at that point, right, to get them through our institutions. We know, we can predict, we've got years of evidence that if we take a kid with a certain score on a GRE exam or an MCAT exam or a DAT exam, that it's highly likely they're going to be successful. What's interesting, if I can give you an analog to medicine in terms of not using the data. So MCAT scores from anywhere from 24 on the MCAT to a 34 on the MCAT, right? So the MCAT, the highest score is 45 on the MCAT. The average score of an entering medical student is about a 30 in the country. But from 24 to 34, there's no difference in graduation rate. Cut it by race, ethnicity, cut it by socioeconomic status, cut it any way you want. The only time you see a minor 2 percentage point difference is when you layer on socioeconomic status. So low income African American, low income Hispanic, they tend to struggle more when they are in that range of MCAT score, right? But that's a small number. So the data on graduates of medical school is like, so 97% of all students that come into medicine graduate, right? And again, in 4 years, in 5 years, it's like 98.9 of the students graduate. Yet, what we do is on the front end in our admissions processes is set up all of these barriers, right? And many of our institutions are not taking students that have those 24s, 25s, 26, 27s on the MCAT, even though the data says that these individuals can get out. Now, let me be clear. If you have an institution, if your school takes the vast majority of your kids with a 24 on the MCAT, it will be harder to graduate those students than if you took, because of the way the curriculum is set up, because of the way the board exams are set up, et cetera, it will be harder to graduate those students than individuals with, if you take a class of all 30s on the MCAT. Your institution will have to work a little harder. Your faculty will have to work a little harder. You'll have to be novel. You'll have to have support systems. So what? All right? So if the mission of the institution is true and we're all trying to create this diverse workforce, which is in almost everyone's mission statements now, it requires us to work a little harder, work a little different, and work a little smarter. Let me just kind of go through. So why do we need to double down our efforts now? Why do we need to think more clearly now? You know, my background before I came to the AAMC was in philanthropy, and I had a very comfortable job, I'll say, in philanthropy. I worked at the Macy Foundation in New York City, and I was a chief operating officer. I wasn't doing diversity work. But what attracted me to this opportunity was that we could think about diversity differently now. That I think as a society, we were able to talk about diversity, not limit our discourse on diversity to race and ethnicity, which has been important and historical and necessary and continues to be necessary, but we're able to broaden out the discourse, which for me brings in more people. And it elevates the conversation from only thinking about affecting a particular group and then having a rationale that if we get more of those individuals in, it's their responsibility to go back to their community to improve their community, which I think the previous speaker articulated it well, saying it's all of our responsibility. Right? And so then the question becomes, if we can think more broadly about diversity, include individuals of LGBT, include individuals with disabilities, maintain a focus on race, ethnicity, socioeconomic status, and gender, now everyone sees themselves as working on these issues. And where's that connection point? And again, it gets to this conference. What do all of those groups have in common? Well, it's been said all throughout this conference, health disparities. So really, and again, it was articulated, diversity is just a tool to solving these much bigger problems that we're out there facing. The lack of diversity is not the problem we're trying to solve. What are we using diversity? What is it that we're, in funny language, but I think clear language for people to understand, what are we hiring diversity to do? Right? You're making a choice to spend resources to sit here at this conference. Unfortunately, we couldn't have food, but that's not HRSA's fault. But what are we hiring diversity to do? Why are we spending so much energy on this? Right? Is it just the social justice rationale? And I think, again, both speakers, Tom Levis covered it well. I think it's beyond the social justice rationale. I think social justice is important, and I, too, come up through social justice ranks in terms of my own background in research and experience. And it firmly undergirds everything I do. However, going forward, I think we are now capable of making a bigger case for diversity and inclusion. And if you look at just the list of things, and I won't go through all of them, think about the research agenda. So people don't think about diversity when it comes to the research agenda, right? But think about all of your research, those who are researchers in the room. What do you research? Things that you care about, things that you are interested in. So it's only common sense that if we broaden out who's doing the research, we too will broaden out the research, right? We think about it from a patient care standpoint, right? And again, we've talked about this idea of concordance. And while I can appreciate the data on concordance, the time it will take to actually get to concordance, that's not, for me, an argument that I can utilize at this stage of the game, right? Because we're not going to mirror the communities and the practitioners in my lifetime, because we are not focused where we need to be, which is down at 3rd grade, making sure that these kids are prepared to be able to pass algebra by the 7th grade and then get into the pipeline. So while we have to do that, there's a bunch of other things that we need to do as well, which is increase and ensure that all of our practitioners are culturally competent, linguistically competent. Well, diversity helps with that as well. Bringing diverse individuals, diverse perspectives, from diverse backgrounds, with diverse language speaking ability, helps ensure that all of our students are being prepared and are in a learning environment that is hopefully more reflective of the society that they will go on and serve. I'll skip through the rest of those. So to do that, we have to reframe how we think about diversity. And some of you may have seen a paper I wrote December of last year called Diversity 3.0. So, and I'll give you the short version here. So the way to think about it, you can read the language up there, but the way to think about it really clearly is Diversity 1.0 was really where we were coming right out of 1954 Brown versus Board of Education. We were thinking about diversity, the need for it, and again, specific to race and ethnicity. We were thinking about our desire for more diversity, but there was this competing thought of excellence. And so the way we thought about it, and you can think affirmative action is probably the most glaring example of it, is that what we really were trying to do is to create diversity, and there was this other argument around it brings down the excellence. So a quick way of thinking about the Diversity 1.0 frame is diversity versus excellence. And that's the way the work animated itself across many of our campuses. It's obviously not limited to the health professions, and it's certainly broader in higher education. But we set up competing structures, separate offices, not integrated, and so forth. And really, I'd say we really began to change that frame, probably with Michigan. There's been a lot of talk about Michigan here at this conference, and my mentor is actually a former dean of the School of Public Health at Michigan, so go Michigan. Go blue, that's right. So what Michigan did in supporting affirmative action in the Grutter case, which was to really Pat Gurin and many of the other scholars there at Michigan, what they were able to do is to help us understand that diversity is not competing against excellence. They actually wrote tons of paper and did rigorous scientific research to show that diversity and excellence are synonymous, right? That you can have this great diversity, and it's really important for the educational environment and ultimately for society. And they did again, great research. And so what that did is that elevated the way we talk about diversity from diversity competing with excellence to diversity being co-equal with excellence. And I think that's where many of our institutions are now. We're in this diversity 2.0 frame. And what I think needs to occur is we need to move beyond 2.0. Diversity is not co-equal with excellence. Diversity 3.0 is diversity drives the excellence we seek. It's a tool. It's something we harness to push, to propel the excellence. And what is the excellence that we seek? Well, just look at your mission statements. Everyone asked me that. Someone asked me yesterday this question. Someone said, you know, our institution, they're all about getting more NIH dollars. And so if we link the diversity to that, I don't see how we'll make the connection. And I said, well, go back and read your institution's mission statement. It says nothing about getting more NIH research dollars. Every one of your institution's mission says something about advancing, promoting the health of the public. All right, paraphrasing. It's funny, I think when I look at all of these mission statements, there's probably one person that wrote these things because they all sound exactly the same and they're expertly written. I mean, these are perfect documents. And so how I define excellence is repeatedly meeting your mission year in and year out. Right? And institutions do that differently, right? We're not monolithic institutions. Some are more focused on creating the academic nursing, the faculty of the future. Some are out there creating the practitioners that are necessary to get on the ground in 18 months, right? We all have different folk, and within institution we have separate missions, right? Whatever that mission is, are you achieving it? Are we measuring that you're meeting that mission year in and year out? And then the question becomes, how does diversity accelerate our pace to mission achievement? So that's kind of the reframing, again, that the previous speaker was talking about. I think we didn't work together on our presentations, but I think that they're synonymous in our thinking about it. But what would that look like? Well, this is how I think about, you know, you've all heard of the tripartite mission in academic medicine, right? It's similar to all of our academic institutions, right? It's research, patient care, and education, right? But if you notice, diversity, I'm not saying diversity is core, right? That's a value that a lot of your institutions say. Diversity is core to who we are. Sure it is. I got it. That's great. But if just think about that for a minute. Core to who you really are is about improving the health. It's what your mission statements say. Improving the health of the public. So that's actually in the center. That's the target. Diversity and inclusion are in that blue band. And again, that just becomes a tool to drive, to utilize. There are other things I could put in the blue band, right? Better understanding of the social determinants of health, right? That's not the goal, that's not the target, right? But it's a tool to drive the goal and target. And if you notice, where is it done through? It's done through those, what academic medicine, which I changed the language, they call that the mission area, patient care, research, education. I actually don't think that that's the mission area. We just are not artful in our terms. Those are the function areas that we use to drive the mission, right? Even if you look at, another question I get all the time is, you know, about the NIH research enterprise and how does this fit in? Go read the NIH's, or Google it, their mission statement. It too ends with improve. Why are we doing all of this research? All right? Why are we doing this work? Look at HRSA's website. Look at ARC's website. Look at HHS. Look at the mission. Why are we doing this? While it might use different words, and these are my words saying advancing health equity, they all mean the same thing. And the question is, are we using all of the tools at our disposal to drive health equity? Right? So at our association, we've got all of this wonderful work being done on variations of care, geographic variations, hospital readmission rates, and it's great work. But what I keep pushing is, think about who the variations of care are on. Right? Think about what causes variations of care. Right? You can't solve any of those problems without disaggregating data and paying attention to racial and ethnic disparities that exist. You can't solve the readmissions rates in any of these hospitals without, you can't solve it for one, you can't look at the data and go, look, we're doing better, and then you disaggregate and you see for a certain set of the population, you're not performing any better, or you may be performing worse. So you're not actually solving the problem. It's not until we disaggregate data and begin to understand that we have to have a lens of diversity and inclusion into our drive for advancing the health of all of our communities. And so that's what we've been trying to shift in terms of our thinking broadly in academic medicine. As that video displayed, it's just clear to me that if anyone in this room thinks that the Accountable Care Act, right, healthcare reform, is going to solve those big issues, it is not, right? It's giving access. There are many other, which we've heard through this conference, benefits, and I'm a huge supporter of this reform that we're going under. But if we don't reform ourselves as academic institutions and begin to play a part in accelerating that change that reform is bringing to us, we're not going to have the success that we are striving for. So let me just sort of pivot to what I think is necessary, because I think enough of us in this conference have laid out the problem, right? And why haven't we solved these seemingly intractable problems? Well, clearly we have this gap. It's a gap between knowing and doing, right? So I can stand up here and tell you with data and analysis what the problems are. But if you ask me what's the solution, what I quickly begin to do is to give you a litany of programmatic efforts that are in the literature and not repeated by anyone else, but good quality work that someone is doing. And I just thought, and if I'm at an institution, I tell you, here are the 10 things we're doing in terms of our pipeline or in terms of our faculty development, right? That's our default mechanism when someone says, what are you doing about diversity and inclusion? But if I just ask this simple question, of all those 10 things that you listed as effective interventions, I'm now cutting your budget in half. Tell me which 5 of those 10 are you going to keep because you know that they are the most effective? No one has that answer because we don't grade the evidence. The evidence hasn't been graded. So we have what we think are best practices. I would submit they're probably promising practices, again, because they haven't been graded. But in the absence of that deep understanding of what works and what becomes generalizable, what we do is we keep recreating the same programs over and over again, even within an institution. If I go to Michigan Medical School and I go to Michigan Nursing School, I see parallel programs, right? If I go to any one of our institutions, and the best schools, at least the people have lunch with each other and talk about their shared interventions. But they probably still don't share budgets, or they still have different kids in the programs, and they're all working at high school level, right? And so we've got these parallel structures. And again, it's because it's not only a knowledge doing gap, there's also just putting things in the literature doesn't translate down to the practitioners. And one of the interesting things that I found in kind of going around the room yesterday, those posters were fantastic, but when I would ask, and they would give me more details, I said, oh my God, that's something to write about. Are you writing about that? The retort is, I don't have time to write about it, I'm doing it, which is accurate, right? So the people best positioned, all of you in this room, to write about this, to do this, to translate the knowledge, are busy executing the work. So there's a role for HRSA, there's a role for associations and organizations to embed ourselves in a way so that we can help articulate what's happening and translate this knowledge and fund some of that kind of work, put specific grants to bring someone in. And I don't just mean evaluation, by the way. We know evaluation is important. We've talked about it for a long time. I'm actually talking about real-time data that allows me to know that this intervention is working right now, or I need to shift resources somewhere quickly because I can't afford to wait another generation before I do a full evaluation and those kids go into college or they don't, right? Or they go into a health professional school or they don't. I need dashboards, which was also sort of talked about. So for me, what's been missing is not a lack of imagination, ingenuity, creativity, and innovation in the space. It exists. I've been to 42 medical schools now in the last 2 years, I have yet to find a school that doesn't have a fantastic, innovative program trying to increase the diversity of their students. I have yet to find an institution that is not at least talking about the social determinants of health and understanding the health disparities. But what I have found is limited knowledge sharing between institutions of what works. So everybody, again, has their parallel structures, yet I travel to one institution and there's this fantastic faculty member doing all of this wonderful work. And then given the technology we have, why are we not piping that person into the school down the street? Right? Or translating to another university within the same system or another school within the same system, right? Because our structure is not set up for, we're not integrated, and we're certainly not aligned. And so I think that those are the things that sort of impede upon progress. So in the absence of sort of capturing the knowledge and an absence of shared learning, there's no opportunity for real translation, right? And translation, by the way, is the big buzzword now, even in a place like NIH, for example. How does it translate? Who does the translation? Right? How do we get it out to the community? Who knows how to do that? Again, it's the people in this room, right? This is what you do on a regular basis. So how do we take, this, by the way, I should say, is adapted from kind of lean management, which is kind of my background and my interest, is sort of being able to say, how do we harness innovations and translate them? I think you used the term scale. I actually think scale, this is not to be negative to your presentation, it was a fantastic presentation, just a shift, and just a mind shift that I want people to think about. Scale is actually not what we're looking for. Scale is McDonald's, right? Wherever you go, across this country, across the world, you see a McDonald's, it's scaled. You know what's in there, right? There's a Big Mac, there's a Quarter Pounder, it might have a different name in a different country, but you get it, you can order it, right? That's scale. That's not what we need in terms of the interventions that we're working on. We need spread. The difference is, spread is Chinese restaurants. Go to a Chinese restaurant down the street or around the corner, it's different. Different community, different flavor. They come from a different place, different flavor. It picks up the nuances of the environment, right? So spread is what we need. What we need are those promising practices, but we need them to have the nuance of a Michigan, right, which has a different mission from an institution down the street or around the corner or in a different state. Right? New Mexico has a different mission. They shouldn't just take what one institution is doing and plop it into their place. What they need to do is to adapt it. But where's the resources to do that? So this is where I give you my commercial. So what we're trying to do, armed with all of that as background fodder, what we're trying to do is to begin to uncover what works. That's the first part. And so we're pulling together, we have a learning collaborative that we're pulling together in partnership with an organization that would be surprising that an organization like mine, the Association of American Medical Colleges, is partnering with the Association of Public Land-Grant Universities. Well, why would I partner with Public Land-Grant Universities, that association, and in fact their Urban Serving University Core? Because remember, I said it's about mission. So what is it about the mission of a land-grant institution? What do they exist for? Outreach, community, engagement. Read their mission statements. So in my simple mind and way of thinking of things, if I can't do it with them, if I can't uncover what works with institutions who are comfortable defining a catchment area that they will be responsible for, and willing to say, we will translate what we are doing in our academic environment. We are willing to work with the K through 12 system and take those kids from the community in which we reside and get them through our institution and on to practice. If I can't do it with those institutions, who can I do that with? So we've created this partnership. We were fortunate to get a cooperative agreement with the NIH for $4.2 million to get this off the ground. We had 17 institutions apply to be part of the Learning Collaborative. We only have funding for 5 institutions. So all 17 have, 16 I should say, have applied. And next week we're going to finish our review process and have the 5 institutions named in early September. So what I'm really trying to figure out, this is what you would call a place-based initiative, this Urban Universities for Health. This is about what is the role of an institution. I talked a little bit about an anchor institution yesterday. So what is the role of an institution who, is the institution just happen to sit in the community, or are they really of the community? And how does an institution that is of the community behave? And how is that different from an institution that just views themselves as, being in the community? And so that's the part of the uncovering part that we're looking for. The other huge rationale to this project is, I believe leadership is extremely important. And what I believe is every one of you, when you leave this meeting, are going to go back to your office, and you've got 2 piles on your desk. You've got your important pile, and you've got your urgent pile. And when you get back to your office, you're going to do everything that's urgent. You're going to work on the urgent. Now, where is diversity, disparities, and social determinants of health? For most of it, it's really, really important. But why is it not urgent, even after coming from a meeting like this? Why is it yet to become urgent? Because we don't know what to do. We don't have the capacity to execute on it. We don't have the roadmap. I can't figure it out right now. It's really important, but I know I need to call this person back because I know how to dial this number and get this done. What's the other reason we do it? What differentiates important and urgent? Someone is holding you accountable for that urgent. Someone is asking you for something today when you get back. Your phones are buzzing right now. You've been gone 2 days, it's too long. You know we have this to do. You've got accreditation coming up. That's urgent, right? Who's holding you accountable to do better on diversity, to focus on social determinants of health, and eradicate those health disparities, right? And the other one is not only are you being held accountable, but you're being measured and graded on your effectiveness in those urgent things, right? There's a dashboard for it, right? And this comes out of my own work in financing. And when I was doing finance at the foundation, we had a dashboard for everything. I knew where every dollar went. I could see it. I can see if it was going down in the market. I managed the endowment. I could see if it was going down or up in the market, real-time data. I can call up and ask for explanations, find out what's going wrong. I can call and celebrate when something was going right, and I can do all of that in one day. When it comes to these issues, we have no dashboard. We have no accountability. So what Urban Universities for Health is doing, and I should say health is an acronym, by the way, which stands for health equity through alignment, leadership, and transforming the health workforce. So if the leader of your institution, the dean of your institution, or you are the dean at your particular institution, do you have a dashboard that you're looking at that lets you know year in and year out you are executing effectively on developing a diverse, culturally competent, linguistically competent workforce? I haven't seen it. Right? Actually, one institution is probably the furthest along, and that happens to be New Mexico. And so the first thing that has to happen is these institutions have to agree that we're responsible for this catchment area. Could be the state, could be the city, could be the region, if you're the only institution like the University of Washington for 5 states, right? Or New Mexico again, and the only institution in that state. Once you define... No, in terms of academic institutions creating the physicians for those 5 states, the WWAMI program is what I was referring to, I'm sorry. So, I'm speaking in academic medicine, I'm sorry. But if you're that institution that is responsible for creating the workforce of that community, right? If that is your charge and your job, shouldn't you be monitoring that on a regular basis? Shouldn't you be monitoring if the disparities are going up and down in your particular state? Shouldn't there be some connection as the 3 Ds are asking us to do? Right? There should be some correlations between those initiatives, and I think that fundamentally has to be done through creating metrics. So what are metrics? And I think what I think is always missing in the conversation about metrics. We got some music. Good. I don't have the dancing gene, sorry. Sorry, Tom. So what I think has always been missing in the sort of conversation around metrics, or it's forgotten. What is a metric tied to? Anyone? It's difficult, right, to answer. What is a metric tied? You have a financial metric. Why do you have a financial metric? Why do you have any metric? Who has a metric right now that they're using at their institution to measure something? There better be one hand go up. Or this is bad if we don't have any metrics for anything we're doing. So I'll make it easy. So metrics are tied to values, right? You only measure the things that you really value, right? So you have financial metrics because you value being a financially healthy organization, right? Many people have that written in there. But again, how many of your institutions has something about diversity being a value? Half hands going up, because you know what the next question is, which is, so how many are measuring it? And I don't mean counting people. Let me be clear. How many have a measure? How many people have something around creating an inclusive environment at our campus? So we're going to be the most inclusive institution. How many people are using the word inclusion at their institution? Few. It's actually very strange. So every institution I come across nowadays has something about being, a diverse and inclusive environment. Certainly industry is probably 10 years ahead of all of us in academic medicine. And why? Because they have a for-profit motive. And they recognize that if they don't have happy people working at their place, able to sell their particular product, and they can't connect with the community, they're not going to be as successful in selling the widgets that they sell. And I think we have to adapt that. We're not selling widgets, right? But what we are trying to do is to improve the health of those individuals in those communities. And so we need to ensure that our environments are healthy, that the people that work in our environments are healthy. Well, you have to measure that. You have to do that through engagement surveys, satisfaction surveys, right? And you create dashboards for that. I'll give you one last just glaring example about our inability to think clearly about metrics. So I was at a particular medical school, I was giving a talk, finished the talk, I sat down, the CEO of the hospital system, who was only been on the job for 2 years, said to me, I told my community, I told this committee that I have, that I want you to go away and develop a metric around collaboration. And he said, and the team came back and said we couldn't do it. It was impossible to create a metric around collaboration. And I said, to me, that's the simplest thing, right? So your metric would be, so how many grants now have multiple PIs on it from different institutions, from within your institution, from different schools within your institution, right? How many papers are now being written by multiple individuals across, showing collaboration? And he goes, I never thought about it that way. It wasn't mission focused. He was thinking about it, he wanted them to start measuring how many different people are having lunch with each other. Well, who cares how many different people? I mean, it's nice, right? We'd like to get different people to sit at the table together, and that's great. And maybe that fosters the kind of change and conversation we want. That's great. But what do you measure? Right? Who's going to walk around and count, okay, there's some diversity at one table, we're doing good. No diversity, we're doing bad. It's about your mission and tying it to mission. So what I'm excited about, and what I really hope HRSA will be as excited about, is this shift that we're trying to change. This shift that we're trying to occur in all of the health professions. UHealth is not about medical schools. The reason why we went to the APLU is because we wanted to be with university presidents so they could be the one, when you get back to your institution, that they're holding the deans of the health profession schools accountable for creating a diverse, culturally competent health workforce. So we're talking public health, nursing, dentistry, and the allied health professions as well. The key in this theory of change that we have here is really in the middle, which is we don't have the strong evidence base, and we don't have the tools currently to sustain the change, which again was articulated well by the previous speakers, so I won't go into much detail there. The increased capacity to execute on this work is about not creating a new office of diversity affairs or a minority affairs office who's going to do all of this work, because it's not going to happen. This is about all of us engaging in this. Do you need someone responsible for it? Without question. Someone that is doing the measurement and monitoring all of this? Absolutely. But all of us have to work collectively in this. So what I really am hopeful of is that when we develop this dashboard and these metrics, I've been racking my brain about who owns it. Where does it sit? It doesn't belong with us at AAMC. It doesn't belong with APLU. It actually belongs with HRSA. So in my mind, what we're really delivering is this is a workforce initiative, number one. So NIH is not going to own it. What we did with NIH is to get them excited about the health disparity component to it, right? It's the Minority Health and Health Disparity Unit that funded it. But what this really is about is helping all of you as grantees, as institutional leaders, as employees at the university, as leaders of the university, being able to drive and sustain change. And I think the best place for that, to lead this effort, to own this data, to continue to work on it when other institutions are no longer engaged in it, whether that's mine or some other institution. To me, we're delivering this really for HRSA. So I'll end there and say thank you so much for allowing me to be here and participating and learning with all of you. Thank you. Questions? Sure. It's up to you.
Thank you, Dr. Nivet. I'm delighted that we have some time for QA. So I want to invite folks to come to the microphones and introduce us along any questions you may have. And while someone's coming up with things, while you're thinking, I think Dr. Nivet was the perfect capstone for the summit, and I want to acknowledge you, Dr. Nivet, for what you presented. You started by saying, I think it's already been said, I was struck by, I was looking online, and I put my phone over there. Oh, you can't hear me?
No. It's turned off. I turned it off. Sorry.
Wow. Thank you. All right, so I was thinking, wow, it's really quiet, and I looked up. Again, thank you, Dr. Nivet, for your presentation. I'm inviting folks to come up for QA. The circle here already heard, but for everyone, I want to invite people. We have time for some questions and answers, and if you'd like, there we go. Great. Okay, so do you have a lapel on you as well?
I do.
So
yeah.
Please.
Julie.
Mark, thank you. That was truly a brilliant capstone. I was thinking about your point on the limited sharing of information, and as such a critical feature of what we do. And I'm wondering if you can comment on either examples of incentives for all of those things, because I do think that there's a wellspring of ideas. But the reinforcement, the DNA, whatever it takes to actually make sharing a part of that, I don't know that that's a part of our being, and not that we wouldn't share. It's like that next step. So if you could comment on that.
Yeah, well, thank you for the question. So I think that sharing is in our DNA. So, but our modality of sharing is tied to our incentives of promotion and tenure. So our way of sharing is putting it in the literature, right? So those of us in academics, right? Those of us that are, the vast majority of us that are getting, whether it's HRSA funding or some other programmatic funding, we write these reports to you, and they don't come back, And I'm not sure historically, because you may have changed it since I was a funded person, but we're not sort of graded on the report, or I wasn't graded on those reports. But even if I was graded on those reports, I had no incentive to share that with my colleagues. In fact, I probably had disincentives because there's limited funding, and so if I give you all of the things that I did wrong and you make all of the perfect grant application, right, I'm setting myself up for greater competition, right? So that's not limited to HRSA, that's just how grant making, unfortunately, has been done because we live in a world with limited resources, right? So the incentive, I think, to change that behavior is in the philanthropic community, federal and private, in demanding, just as we do an evaluation component, demanding a dissemination component that is not limited, asking and being clear that dissemination is not limited to publishing this data. It's part of it, but actually allowing for a funding mechanism where there would be these kinds of meetings would be all about organic sharing of what we've failed in, right? We're not incentivized to talk about our failures, but that's actually where the best learning happens. It was interesting going through this grant making process for the UHealth project because we had to consistently say, and this is awkward, the school that might get the highest score in terms of their grant application to us is the one that had the most failures. And our reviewers, we had to keep telling them that if the school says they tried this, they tried that, they failed, that's actually going to be the school that is most generative in bringing knowledge to the table, because this is a learning collaborative, and the deliverable is actually learning. So you want to learn from those who've tried a lot and had failures. And that's not, there's no grant agency out there saying, we're going to fund you to talk about your failures, right? And so we need to figure out how to create those mechanisms where people are free to share what didn't work, because that's as important. And again, in a time of limited resources, I need to know what the school down the street didn't do well. And in fact, I probably need to partner with them and leverage resources. So I think just a couple of quick things. Supporting that in the grant applications, fostering more collaboration. HRSA is the best place to demand. Again, none of this is meant to be critical, and I know it will sound, and the audience won't like this either, but even the grant mechanisms are all set up in silos. So you've got these mechanisms for this, for that, and for that. It makes sense to me when you're funding at the faculty level or even at the programmatic level, maybe even at the higher education level. I don't think so, though. But once you start getting down to these pipeline programs, it doesn't make any sense to have these silo, to me, and again, as I'm not picking on HRSA, every entity and agency does this. It needs to be cross-cutting because these kids don't know what they want to do. So we need to be leveraging these resources. I remember writing my first HCOP grant. I literally wrote, I remember this, I was going to take 100 junior high school kids, and I said in my grant that 80 of them were going to be doctors and 20 were going to become dentists. I literally wrote that. And so what happens years later, right? 4 are doctors, 1 is a dentist, several, 45, 50 of them graduated college, but I didn't tell HRSA that success was really, I'm just going to get these kids and make them healthy, happy adults, get them through college. That's my measure of success. And my bonus is they're going to do, some of them will go on and be lawyers, doctors, whatever, because I wouldn't get points for that. This is 15 years ago, right? So, but I'm not sure we've adapted our thinking enough to really appreciate that when we're talking about children, and at least, again, I'm limiting this to the sort of pipeline interventions, we need to be a little bit more clear on what success actually looks like. Long-winded answer, I'm sorry.
Dr. Nivet.
Yes?
Could you tell us how to get access to that video? We weren't able to find it.
So it's online on our website. AAMC.org, which is our website,
Right.
/diversity, and it should be right there on that homepage, the diversity homepage. Well, let me just say thank you again. It's been wonderful to participate for the 2 days, and I look forward to talking to all of you. I exchanged a lot of cards yesterday, so I hope people will feel free to follow up, because I really do believe that if we sort of work in a collaborative fashion and we don't think of ourselves in these limited ways that other people define us, that we have a lot to leverage from each other. So thank you so much.